Hello everyone and welcome to another Learning Lunch hosted by Format Approved. My name is Brian Johnson. I'll be your host for this session. I'm the Senior Director of Online Education with Format Approved. Our topic today is Next Generation Technologies Drive Accountable Care Organization Performance. So we all hear a lot about ACOs, but we're very honored to have a great expert on this subject with us today in the form of Mark Anderson of AC Group Care 360. And so you can see here a little bit about our presenter. Thank you so much for joining us today, Mark.
Thank you for inviting me.
And so I'm going to let you look at his qualifications there, which are quite extensive, and you'll see that we are very fortunate to have him with us today. While I just cover a couple of quick housekeeping notes. The first is that people always ask us, can we get the slides from this? Can we get the recording of this? Well, I want to assure you that we're recording and we're going to send a follow-up email where you'll get the slides and the recording and various other resources that we want to make available to you for attending. And even if you don't attend, if you registered, you'll still get those resources. And then I'm going to let you look at the questions we're going to cover today while I discuss questions that might come from you. So at any time during the presentation, you should feel free to ask questions of our presenter. That's a big part of why he's here. We're going to hold those questions till the end just so we don't run out of time and throw off the rhythm. But then if at the end we don't get to all of the questions, don't worry about that because we're going to give them all to our expert and he will then respond to those in writing. So do take advantage of that opportunity to ask him questions and we will be sure that you get answers after the session if we don't get to all of them today. All right, that concludes our housekeeping notes. Let's go ahead and get into the subject. Thanks again for joining us today, Mark.
Well, it's a great time to be talking about these kind of things because everybody has interest in what is the technology going to be really required as we go forward with these ACOs and value-based reimbursement in the near future.
Yeah, you hear a lot of talk about ACOs, but I think many people, including myself, are still very hazy on the details. So let's get into our first question, if you don't mind. Are ACOs improving quality while reducing costs? I think that's the promise, right?
Yeah, I mean, that's what the whole design was supposed to be, is if in this case, ACOs are mostly Medicare funded, although some of the Aetna, Cignas, Uniteds, and the Blues are starting to provide some funding for this. But if we provide funding to a hospital or a health system that has hospitals and doctors, the assumption is that we're going to be able to save money by keeping that patient that has chronic diseases healthier. Although a patient that has a chronic disease, of course, never gets healthy, but there's a lot of things we can do. But we really need to start by looking at a few of the statistics out there on how many of these ACOs are actually making money. That's on the next slide. So if you look at all the organizations, and there's basically 220 Medicare shared savings programs for the ACOs. The interesting part is only 24% of the ACOs have actually earned the shared saving bonus. That's where they're getting paid for taking care of the patients and getting the bonus on that. 3% have achieved the savings, but not successfully report. So again, on all of this, you have to not only do the work, you also have to report the data back to CMS. 27% reduced spending, but could not earn the actual bonuses. So they saved some money. But 46% of all the ACOs out there that were established did not even get any savings. So the question ends up being, when you go back and look at that 46% compared who did not get the savings to the 24% who got the savings and earned the bonus, what we found is the technology was probably the biggest driver. The ones who did not receive the savings did not have the ability to share all information about that patient for all of the caregivers. They had portions of it, just the hospital, just the provider, but it came down to the biggest ingredient was the right technology who brings all the data together to overall drive quality improvement and reduction in costs. So that's one of the challenges we have today is if you're going to get involved in this, you got to make money. And really, why are we, yeah, that's okay, go to the next slide. Why is all this changing? And what's happening with this? So you go back and look at 2010, where majority of everybody was fee for service. In 2015, we're looking at a more of a driving force where fee for service is starting to go down, and we have more of this full population care, which is we call it, capitated care, or what I'm calling value-based reimbursement, which I'll explain later in the future, a little bit later here, but also partial population care, conditional care. So it's starting to change now, but by 2020, we're probably going to be much lower on the fee-for-service, and you're looking at more of that 50 to 60 to 70% of our reimbursement is going to be based around how do we take care of people with chronic diseases. If you're an average person who doesn't have a chronic disease, you're still going to be fee-for-service in most cases. But we're moving away from paying for services and paying for quality. And it's going to be more of a capitated payment, either on a yearly plan or a monthly plan per patient based on their chronic diseases and their conditions. So it's all going to be changing. And if you're not prepared today, you're going to be way behind. Now, I put in here 2020. The government says 2018. That's when they're going to go into this. 50% of all Medicare payments are going to go towards population health type stuff or value-based reimbursement. And the Aetnas, the Cignas, Uniteds, and Blues have all said the same thing. But I don't think we're going to be fully implemented probably until 2020. It's going to take a while to get everybody working on it, but it's going to be changing, and you better be prepared for it. Next slide.
Well, that's really interesting because 2020, even if it's a little slower than the government's promising, is still right around the corner. So I think you're right that a lot of people are going to be struggling to be ready. But maybe we should go back and look at why is this payment system changing at all?
Well, again, if you go back and look at where we're spending and comparing us to the other countries that are out there, we spend a lot more money on healthcare than anybody else. So on the next slide actually kind of breaks it down by each one of those states. And of course, right now, we're still buried in paperwork. It's one of our problems. That's why that little slide is.
Right. Typical healthcare administrator.
Yeah, and the funny part is we're now moving towards electronic medical records. We still have all this paper. There's still a lot of things that are paper-based, especially workman's comp cases, personal injuries, auto injuries, all still paper-based. But again, going to this slide here, we spend twice as much than any other, strong country out there on healthcare. And yes, if you have an auto accident, you get shot or anything, we have the best healthcare system in the world. However, healthcare, we're terrible at health. We're great at emergencies and chronic, real issues that are, life-threatening. But we spend way too much money because there's no incentive for the hospital people and the doctors to really cut costs. The more they do, the sicker you are, the more money we get paid. We have to change that. And you go back to the Scandinavian countries and even Europe. Yeah, the euro is different from ours, but we're spending a lot more money because we're not trying to keep people healthy. And part of that keeping people healthy is going to be patient engagement, getting the patient to be responsible for their own health care, to help find ways of cutting costs. But today, doctors want to do surgical cases. They want you to come to the hospital. We want to see you in the visit. We don't get paid for monitoring your health. We get paid for an episode of care where you show up in our office. We got to move away from that and start providing incentives to monitor patients' care, provide preventive health stuff so that you are somewhat healthier. So if I can eliminate one ER visit per year for a patient that's diabetic, I can save $5,000 or $6,000 a year. So again, we got to move towards that new model. And a lot of these other countries are more, they're more socialized medicine and things, but it's all about reducing the cost down a little bit every single year instead of having a raise 40 or 50% a year that a lot of people are seeing today.
Well, let's look at the quality of care. Yeah, go ahead.
Yeah, so it really comes back to, we've been talking about this stuff really since probably 1999 or so, where we go back and look at, are we meeting the quality indicators that are out there? And it's interesting, the breast cancer, prenatal care, we're doing pretty good. We're into the 75% of it. But you start looking at people that have other issues out there. Overall, only about 55% of all care quality plans are being met. And when you come to chronic care, it's 56%. We have way too many issues going on where patients are not following the clinical protocols that the quality measures have set up. And it might be the pediatrics. They have clinical guidelines they want everybody to follow, and we're not meeting any of those guidelines. Partly because we don't get paid for meeting guidelines. We don't get paid for people coming in and getting preventive tests done. Go get your foot examined, go get your eyes examined, all those other kind of things. The medical doctors are not paid for any of that. They have no incentives, no financial incentives, and no penalties if their patients don't meet these requirements. So again, that's why we're trying to drive a new system where there are incentives to have people meet all these quality indicators out there today. And and again, why is it an urgency? You start looking at where we're spending our money and what the increases are, and what percentage of our money is being spent on national health care. Everybody's been talking about our costs are going up, and even under Obamacare, the interesting part is from most of the insurance plans, they're raising the rates by 30 to 40% a year. We can't afford to have that kind of rate increases every single year, so we got to do something, and the urgency is there now. Yes, more people are covered. If you're a patient, if you're a young person that had a chronic disease or an older person that had a chronic disease, now you can change employers. You've got health insurance. You're going to get covered. But for the majority of us that are healthy, our costs are rising tremendously, and the overall change has still been an increase in cost. Healthcare cost has not gone down at all. It's still continuing to go up, and it's becoming a bigger portion of our overall healthcare system. The whole, the United States system. We're spending way too much money on healthcare, even though we got, good for emergency type patients, but our health is not that good either. We have more diabetic patients, more people that are obese today than ever before. Our ratios are so much higher than any other country. We got to do something different, and that's why we're moving towards this accountable care, making the physicians, the hospitals, the care providers, and their family and the patient accountable for their own health care. That's why we're trying to move to that model.
Well, and obviously this can't keep going up forever. I mean, costs could go up, but as a percentage of GDP, at some point it becomes, the snake that tried to eat the hippo. It's not going to, you can't grow as a percentage of GDP forever.
Right. And again, my rates have gone up 30% a year with my health insurance plan. And the only way for me to keep that cost down is to raise my deductible. So my deductible in 2010 was $1,000 a year per member of my plan, so me and my daughters. Now I'm at $7,500 per year per person.
Wow.
So that means paying out all this money for my insurance and paying the first $7,500. I got to go back and look at it and going, why do I even have health insurance? I'm paying out almost $17,000 a year for me and my daughters, and we never use that much health care.
Yeah.
But we have chronic diseases. If I had a chronic disease, then all of a sudden we are spending more than that. So the model is it takes care of people with chronic diseases, but again, there's no incentive, there's no accountable care for that. That's why we got to change. We're spending so much money. You look at hospital care, 30%, physician care, 20%. All kinds of things are broken down. But we got to find ways, and I came from the hospital side. I spent 25 years in hospitals. We need to cut the hospital care down. That would be the hospital emergency room. Maybe spend more money on other health spending, more on personal health, and less on the hospital side. And maybe cut down the physician side, but provide better quality, more physician visits, and keep you out of the hospital. If I can cut out 10% of the hospital costs by keeping you out of the hospital, I can spread that money over other things and more preventive care, which is what we really need to be looking for.
So you mentioned this term earlier, Mark.
Anytime I ever have to go to the doctors when I break something by doing housework. So I decided housework's out for me now.
Yeah, too expensive. So I don't know if anybody can hear that clicking noise. I'm not really sure what that is. I don't think it's on our end. Yeah, we have a couple people talking about it. Mark, do you hear the clicking? There's nothing. Oh.
I'm not hearing anything. No, not on my side.
Huh. I'm a little confused by that. I'm not sure what could be causing that, unless it's a something with the network. Hopefully, it's intermittent.
Hopefully so. So I'm not hearing any clicking at all. So mine's quiet on my side. Okay.
Well, let's try to continue, and hopefully it'll go away in a second. You mentioned this term earlier. What is value-based reimbursement? So someone suggested I mute my line. Let's see if I mute my line if it goes away.
Okay, we'll see. Yeah. Just mute yours and come back in when you need to ask the next question.
Okay.
Yeah, value-based reimbursement is kind of a term that we've kind of morphed into. Originally it was accountable care organizations, but as the healthcare plans get involved in this, it's really about paying for the value. So we had fee-for-service reimbursement, now we're going to call value-based. Value-based reimbursement is really moving to accountable care for any patients that have chronic diseases. And today, about 37% of the population in the United States has a chronic disease, but they're generating about 65% of all the costs. So it's all about creating this accountable care for those patients with chronic diseases. Again, it was initially started by CMS, and they were calling them accountable care organizations. At least what the healthcare plans have told us is 50% of all the reimbursement from Medicare, Medicaid, and most of the large healthcare insurance plans are going to come from quality-based incentive plans where the health system, which will be a combination of hospitals and doctors and pharmacists and everybody else out there, will get paid a lump fee per year per chronic disease patient. For example, you may get $10,000 a year per diabetic patient that's in your system. And then you'll also get a quality performance incentive. I don't want to call it a bonus because that sounds different, but these are incentives for meeting those quality indicators. Remember the one screen, we're only meeting 50% of the quality indicators today. In the future, they're going to want you to meet 50, 60, 80, 90%. And if you want to get full reimbursement, you got to be close to that 95% of all the patients are meeting those quality indicators. And the quality indicator might just be the A1C value is being managed, that your BMI is not increasing, it's staying stable. But it's going to be built around quality indicators. You'll get a base fee plus a quality incentive for taking care of those patients with chronic conditions. And again, it does not affect the average healthy person, but anybody that has a designated chronic disease. There's about 5 major chronic diseases that we're monitoring today. The interesting part is cancer is not one of them, but it's basically diabetes, CHF, asthma, hypertension, obesity, things like that they're really monitoring, and that's how they're going to break out the payment system. So it's a new payment system around accountable care.
Mark, I'm going to ask you to hold on just 1 second because we're still getting that clicking. I just want to see if I mute you for just a second if it goes away. Okay, so that it did go away. So I think maybe there must be a problem with your phone line, although now it seems to have stopped. Can you try talking again, Mark?
Yes. Can you hear me okay now? I'm just trying to talk normal.
It's back. What I think we should do, because a lot of people are saying it's hard to focus on you, and this is an important subject, would you mind terribly calling back in, and I'll talk to our audience for a moment while you do that, because it is pretty hard to understand you with that clicking, and I think it may be a phone issue.
All right, I'll call right back in.
Okay. And meanwhile, while Mark takes care of that, I hope everyone can still hear me. I should still be audible to you. I apologize for that. There are sometimes some things that go wrong in these webinars, as you probably know if you're regular attendees to them. Sometimes it's a GoToWebinar issue. Sometimes it's the way the phones just fail on us. But we'll get him back on in just a moment and continue with this presentation. So thank you for bearing with us while we do that. As I said earlier, if you have questions for our presenter, and some people have already asked some questions, so don't hold back on those, although I know we're still in the early parts of it. But if you have those questions, this would be a good opportunity to go ahead and type them in, since we're taking a quick 1-minute break while we try to get a better connection to our speaker. I do apologize for that clicking. I've never heard it do that before, so that's a new one. But it's always in a...
Is it back?
You're back, but I don't hear clicking.
I'm back.
All right. I think maybe we're okay.
Maybe.
Okay. Well, thank you for doing that for us, Mark. I think it'll be a lot easier for people to understand. So I don't know if you just want to quickly recap what you were saying on this value-based reimbursement screen. It was really hard to understand, if you wouldn't mind.
Sure. Is the voice okay right now again?
Yeah, it's actually,
one more time.
It sounds great, actually. I don't hear any clicking and no one else is reporting it. So I think we fixed it.
Good, good. So what I was trying to say on value-based reimbursement, Accountable care organizations, ACO, was the organization. We're moving away from fee-for-service to what now we're calling value-based reimbursement. So value-based is the reimbursement system that they're going to have for people with chronic diseases. About 38% of the population in the United States has a designated chronic disease, which could be diabetes, CHF, asthma, obesity, hypertension, those kind of things. But they generate about 65% of all of the cost. So the government and the healthcare plans want to find ways of controlling that cost of these people with chronic diseases. Again, obviously it started with Medicare, and the other healthcare plans are going to start moving closer to this in 2018. But the goal is to provide, think of it as almost like a capitated payment per chronic disease patient. So an example I always use is the healthcare plan, which could be CMS or anybody else, might pay a healthcare system $10,000 a year per diabetic patient, although it even right now today it costs them about $15,000 a year. And then they'll provide a quality bonus or a quality incentive plan that if that health system meets the quality indicators that have been designated by that healthcare plan, they will get a quality bonus. So the example I always use is I get $10,000 per diabetic patient, maybe 20% on top of that if I meet all the quality indicators. So now that healthcare system is going to get paid $12,000 a year per diabetic patient. And it's up to them, the hospital, the primary care physician, all the specialists to control that cost, where the healthcare plan was paying $15,000 a year for that same diabetic patient. So the healthcare plan saves money, and they're moving all of the risk to that health system to improve healthcare, better model. So that's why they're moving. It's a reimbursement. It's a change in the reimbursement model, while for organizations that are now accountable for the care of that patient. Because right now, under fee-for-service, no one's accountable for the care of the patient. We're here to take care of that one episode, get that episode done, send you back home, but no one's trying to keep track of your health or improve your health.
Well, you can see how this would really put a lot of pressure on healthcare providers, because it's really moving things into their sort of, the risk is on them, as you said. So that's a whole new ballgame.
It is, and the challenging part is who's taking the risk? You know, is it the communities that are part of this? How do you engage the patient? Because it's all about this, they call it the triple aim. You know, better health care for a certain population, better health care for individuals that have that issue, and really lowering the cost through quality and operational improvements. And the challenge for all of this is how do we do it the right way? Remember the slide that was showing only 24% of the organizations actually met these requirements and got the quality bonuses? It's all about, you have to do more than just taking care of the patient. It's engaging the patient, it's engaging the family, getting the community involved to provide better resources for that population of people that have chronic diseases. Example would be is we know that if a diabetic patient gains 2 pounds from the day before, so if I weigh the patient in the morning on Thursday, I weigh the patient on Friday in the morning, and they've gained 2 pounds, there's an 83% chance that they're going to have an ER visit the next 2 days. These are studies that the American College of Diabetes have done. We now need to be monitoring the weight of that patient on a daily basis. So there's new technologies out there that give these weight machines that weigh you, and through a Wi-Fi or some type of connection, that information is sent back to a care coordinator. That care coordinator monitors all of this data on these, say, 500 diabetic patients, and the software comes back and says, of your 500 diabetic patients, 2 of them have gained 2 pounds. And that information goes to the care coordinator who coordinates that care, calls the patient and says, what happened? Did you have a big dinner last night? What's going on? And if they can't determine what it is, then they contact the physician to find out what the physician wants to do. And then it might be a visit coming back, and we need to check what's going on. So it's proactive monitoring of that patient to overall find out what's happening to that patient to, in theory, improve quality. In this case, it's reducing that ER visit, which may save $5,000 and be better for the patient.
Exactly. I was going to say it saves money, but it's also good for the patient because they, don't have that health crisis that gets them in the ER. Nobody wants to go to the ER if they can avoid it.
Yes, and especially with, chronic disease patients, their support system is usually not the best out there because it's hard to take care of those people. And again, it's getting the patient engaged, getting their family engaged, and getting the community engaged. The community's got to be part of this too. Because most patients that are diabetic or CHF or have obesity, as they're part of the community, how can the community help? And the community could be community of hospital, the doctors, the ambulance services, just having somebody can drive the patient to go see the doctor. A lot of people with chronic diseases don't have good transportation. So how do we make sure we build all of that into it? But the goal is this whole triple aim type system. We want to give everybody the rights to everything. We want to eliminate all the duplicate tests that go on. How many times are we running the same tests on the patient multiple times and because no one's sharing that information?
It is astonishing.
Yeah.
You see those numbers.
Screening to prevent. Yeah, in most cases, the numbers we see are 17% of all tests that are run aren't even necessary because the result is available someplace else, but we don't share those results between different care providers.
So we're talking about chronic diseases, and I think you're telling us here that there is quite a problem with chronic disease.
Now, part of it is because obviously we're having more population out there, those kind of things, but the percentage of people with chronic diseases is going up tremendously. We're talking about, 149 million people in the United States have a chronic disease, and that's going to keep escalating up there. And, if you look at the statistics, which is the sad part about it, is a lot of it ends up being early childhood obesity becomes one of the biggest problems. Because obesity runs to diabetics, hypertension, heart disease, all kind of things are driven off of just the obesity thing. And if you look at the percentage of the kids today under the age of 15 that are classified as obese, it's amazing. Numbers I've seen up to 35%. I live in Houston. The numbers, we're known as the obesity capital of the world, I think, last numbers I saw. It's a problem out there. We've got to start working on that now because as these people get older, yes, you might be obese right now, but your time you're 25 or so, you may be a diabetic patient. You're going to have heart disease. You're going to have hypertension. That's just driving up the cost. The average healthy person costs about $500 a year. The average person that's a diabetic patient is costing $15,000 a year. Gigantic difference. So if I can keep 10% of the kids from becoming a diabetic by controlling their obesity or dropping the BMI levels, I can help cut that cost. But if we don't do anything, we're going to be at 100% of a chronic disease by the size of other organizations. So, I'm sorry, other countries. So we cannot have that kind of thing going on today.
Well, you've touched on this before, but tell us more here.
We're talking about this fee-for-service.
Yeah.
Yeah. So, it's a small percentage, because, back in the 1990s, we had capitated programs, but capitated was for everybody. You're getting $50 per member per month, and it was for all patients. That was great for the healthy people, but it really wasn't good for the chronic disease patients. Now, if you look at it, look at these numbers. By 2015, we're still running about 8.9% of all of the reimbursement is coming from these value-based, the incentive programs to improve quality. But because Medicare made the announcement probably about 16 months ago, that they're going to move towards value-based reimbursement, paying on these ACO models, and the Aetna, Cignas, United also all jumped on that. So we could be at 40 to 50% of all reimbursement is now going to be switching from fee-for-service to value-based. Now, that's assuming everybody jumps on right away. I think it may take a little bit longer, but this is what the plan is today, that over 40%, closer to 50% in certain places, of all of the reimbursement is going to come from quality, moving the risk from the healthcare plan to the physicians and the hospitals. And the only way you're going to be able to survive in this is if you have the right technologies for monitoring all this information so you know what patients to work with first. So it's coming, get prepared.
Absolutely. I was just going to add that, you gave the example of the scale, and I know we're going to talk about other technology here as we go on, but there's no way a caseworker could manually, like through paper, monitor 500 patients at once. I mean, it's just crazy to even think about it.
Right, and that's the problem today. Think about the doctor. There's no way for the doctor to monitor 500 diabetic patients. They wait for the doctor to show up in the office and they treat them. We got to get away from that, where we set these quality goals, we measure the stuff for the patient, and then we provide a technology that brings back information to a care coordinator, and then the care coordinator controls it, and then they provide the information back to the doctor. Tell me the 5 patients I need to talk about today. Don't show me the 495 that are in compliance. Show me the 5 who are no longer in compliance. That's what I got to move towards.
Well, what do you need to do to get ready for VBR?
I think there's a couple of basic stuff you have to do. Obviously, the value-based reimbursement is all about looking at those patients and having somebody coordinate all of the care, the primary care, the specialist, and typically that would be make sure you have enough primary care physicians in your network where they can monitor the patients. And a lot of places already have this, but they have to have the technology to be able to monitor this and to be able to provide much better quality performance. And so you have to have the primary care vendors, you have to have the other clinicians that are involved around, provider, incentives for preventive and chronic care. The endocrinologists for the diabetic patients, the cardiologists for the people that have CHF, but getting the whole team together. And then you're going to have to really restructure the physician's compensation to align that provider's incentives around this value-based reimbursement. If they're only going to get paid based on office visits and ER visits, and we try to eliminate that, there's no incentive for them. So we have to change it. We have to provide more of maybe a monthly fee to these doctors to monitor these patients, and then you'll still have fee-for-service for the healthy people. That's why you see a lot of hospitals out there just buying up the primary care physician practices. They're going to put them on salary. But even if you have them on salary, there's got to be an incentive for them to participate in these kind of programs. And the other part they're looking for is really trying to create a patient-centered medical home. Something where that patient could be in their home being monitored, that combines the physician, care coordinator, patient engagement, and I always put in their family engagement, because it's, this is about a community. It's about the family helping that person with the diabetic issue or the CHF issue. The patient can't do everything on their own. I got to improve everything about that. And then really creating what's called care management systems with the right technology that basically does risk stratification, identifies the patients at high risk that we really need to look at, and people that might be high risk in the future. That's where the technology helps, because I can't analyze 10,000 patients on a daily basis to figure it out. Computer systems can do that. But identify that patient who is the high risk, identify those patients who might fall into the high risk categories, and keep them out of falling into that high risk category. But it has to be all about human contact with the patient. It's got to be somebody talking to the patient. You can't wait for the patient to show up in the emergency room. We need to be talking to them on a weekly basis, a daily basis. How are you feeling? And there's some really great tools out there now, with the iPhone wrist things, where I can have information about that patient. How are you feeling today? Get that information sent to a system where the patient's interacting with a person through a computer system for capturing all that information. But basically enables everybody to work with that patient, create a close relationship with that patient, because you're in constant communication with that patient through there's apps you can have on the person's home, or a remote monitoring device that sends that information in. So things we got to do a little differently.
So with the proposed changes to reimbursement, you've already answered this question in a way, but we're going to need new technology, but what does that technology look like?
Well, I think it's an interesting thing, because our technology today is all built around patients showing up. I got to capture the information, but there's not a lot of quality tracking. I need to see a flow sheet that says for a diabetic patient, there's 19 things we got to monitor. I need to have that information flowed over a period of time. not just once every 15 weeks when the patient shows up, but I want to look at a lot of different factors for them on a daily basis. So I need a computer system that can monitor information that's captured in the hospital, information that's captured in the office, but more importantly, information that's captured from the patient in between office visits. So it's that, again, that home monitoring, collecting that kind of information. Because again, the reimbursements can be based on improving the health and quality of the patient. If I'm not monitoring it on a routine basis, I'm not improving health. I'm not helping the patient to figure out how to move towards this model. So again, we have to create new technologies out there. We have to implement those technologies, and then we have to change how we provide care to patients. Because again, I don't want them showing up in the office. I want to provide care in their home. I want to keep them healthier, and that's where the incentives are going to come from. And again, 50% of your reimbursement is going to come from this. That means either you hop on this, figure this stuff out, get the right technologies, or in theory, 50% of all your patients could be.
Well, you know, it's interesting because I talk to people in hospitals all the time. Oh, I don't mean to talk over you, but I talk to people who are providers in hospitals who their EHR and the ER can't even talk to the EHR up on the floors. So, I mean, that's the level of non-interoperability that some folks are facing out there. What are the software needs, then?
Right. So once you decide, okay, I got to do something different, what I really need is a single source for all clinical and financial information, a database. What that means is that I need one database of information that shows who the patient is, what is all their clinical conditions, whether they're in the hospital, in the doctor's office, in the long-term care facility, in the rehab facility, information from their home. You know, and I'd like to have it so that when an ambulance goes out to grab a patient because there was an auto accident or something, that ambulance has, that paramedic has all the information about the patient right there at their fingertips. So when the patient shows up in the emergency room, that ER doctor knows everything that's occurred with that patient. Today they show up, I barely know the patient's name. I may have some information that was in the hospital 5 years ago, but the ER doctor doesn't know that that patient's been treated by 6 different doctors for 5 different conditions. So I need one clinical database of all that information in it, truly interoperable with everybody who sees the patient, plus the patient's data from their home. And then the second part I need is a care coordination. How do I take all that data? How do I analyze all that data to figure out the risk stratification of what needs to be done? And a lot of people are calling that population health management. And I see all these vendors selling population health software. Population health is just one component. That analyzes, you know, the 10,000 patients in your geographic area and says, here are the patients that have diabetic conditions and here's the risk stratification. But I need something that's going to be able to go out there and look at all the patients, create a risk stratification for them, figure out what's going on with them, so I know who to actively go after. So that's just the next part of it. As I mentioned multiple times, the fourth item I have to have is some kind of software with patient engagement, something that's interacting with the patient or their family on a monthly basis, a weekly basis, or a daily basis, depending on that patient's risk. If there's no risk, we contact them once a month. But the higher the risk, the more contact we have to have with them. That basically engages that patient and their family to find out what is going on, how are they feeling, what are their issues. There's a lot of quality indicators we can find out from that. The fifth area is we also need best practice guidelines. These are the clinical guidelines that say if a patient is a diabetic patient that has hypertension and is obese, what are the things we need to be following? What are the care plans we have to have? So a software product that has all these care plans built into it. Now again, the organizations can modify it to whatever they want, but we've got to start with something. It's too hard to have a blank slate. We need to have these quality indicators all built in, the best practice guidelines that show everything that needs to be done so that we can do exception reporting of clinical alerts. So again, who are these risk stratified patients? What are their issues? Again, I don't want to monitor 10,000. Well, I want to monitor all 10,000. I want the software to monitor that. But tell me the patients I need to see today, what are the issues, and create clinical alerts built inside that patient's, that provider's EHR system. So if I'm in Epic or Cerner or Allscripts or NextGen or eClinicalWorks, I want all of these systems talking to each other, that while I'm seeing a patient, I also get a pop-up that says, hey, Dr. Jones is letting you know that 2 of your patients that are you're under the cover, that you're covering, are no longer on compliant. They didn't pick up their medication. They're having issues, or they showed up in the emergency room. I need those alerts to come to the doctor. And it may be more of those things. Once I see the patient, the next thing I see is, here are the patients that are in trouble. Because the EHRs today allow you to enter data in. They don't tell you which patients are not compliant. So all that's got to be built into it, creating this kind of knowledge base for provider alerts. And again, obviously, with the financial assistance, we got to be looking at this as which population is costing us more money. Because again, you go back to that 48% of all the ACOs are losing money, not meeting the quality indicators. I got to know what my costs are. I got to know if I'm making money on this or not. I may decide I don't want to be in this ACO because I'm not getting paid enough. I have to have that financial information with risk stratification to know, is this a good population for me, or what do I need to do to change the clinical protocols to help cut the cost down? That's the first 8 things we have to have.
Well, explain this graphic if you could.
Well, the whole thing here is all about care coordination, which basically means we have to find ways of connecting all of the care providers. Again, today you have a hospital system that has data, and I may have people that, one group that's on eClinicalWorks, one on Cerner, one on Epic, one on NextGen, whoever. I've got communities that have 56 different EHR products. How do we bring all that data together? And how do we bring that data in that also includes, the retail pharmacies, the patients and their home care, long-term care? How do I bring all this stuff together so that I have one medical record for the patient? And the other interesting thing is, as we move through this meaningful use requirement for EHRs, where every single EHR has to have their own personal health record, all of a sudden the patient who goes to 5 different doctors now have 5 different personal health records out there, and none of them are being shared. We need to bring all the data together in one place, one location, where all the doctors can see the information that they need. If I'm the orthopedic doctor, I don't need to see everything, but I got to know that they're seeing a cardiologist. I got to know what medications they're on. I got to know what other conditions are sitting out there. If that patient is a diabetic patient, what's going on with them if I'm doing surgery? I need to bring all this data together, connect all the providers. And under meaningful use stage 2, that everybody always talks about, we were supposed to be connecting everybody. That's what this whole original plan was. Let's connect all the doctors. There's not, right now the requirement is you should try to connect, but there's not a requirement to connect. So we have to connect everybody together. The only way we're going to actually get the improvement. And that's what we saw by going back and looking at the 24% of the ACOs that are making money today. They were completely connected. All the care providers in that community were sharing information about that same chronic disease patient. And ACOs are probably the best way of doing that, or you may call yourself something different, but again, it's all about sharing that information.
So where is the real value in exchanging data within a community?
Well, if you kind of look at the driving part, having the hospital data shared with the physicians provides about 10% of the value. Because the patient may only go to the doctor. The statistics are, for every hospital visit, there's 32 physician visits. So getting the hospital data provides some data, but it's really sharing of the physician data with the hospital provides even more value. Patient shows up in the emergency room. It's great to get all that information from the doctors to the emergency room doctor. That provides some value. The real value, though, is sharing data between the providers. Again, one hospital stay, 32 office visits, but they may have gone to a cardiologist, a GI doctor, endocrinologist, family physicians. We need to share the data between the actual physicians that are treating that patient. That's 65% of all the value out there that we find in this, is if I can share data between the care providers that are taking care of that patient. That's where the real value really kicks in.
So how can this be done then?
Well, there's a number of ways. So one of the examples I always use is up at the Taconic IPA, which is up in New York. There were 10 hospitals up there and 2,300 different doctors. we actually came up with a plan that went through and created kind of an enterprise master patient index, because everybody had different numbering systems for the patients. But how do we determine who these patients are? How do we make sure it's the same patient? So we basically put a system in, back then we called them health information exchanges, HIEs, that basically brought the data in with security and confidentiality and make sure we had a way of identifying who the patient was. But we were able to bring in data from, here's some examples, like people that are, physicians that are on NextGen, Epic, the Quest product, Athena Health, whichever the providers are, bringing all that data together into one place and then allowing the data between the different providers to be able to share that data between them. We basically connected 2,300 doctors and 10 hospitals. All of the clinically important information was shared. And we basically used the CCD record formatting, which is 32 different aspects of clinical data. All of their medications, their vital signs, all of the lab results, radiology results, what doctor do they see, what hospitals do they go to, basic immunization, things like that, bringing all that data together, 32 different data elements, all together in one location, and then that information was stored in a location so we can do analytical work on it, but that when a patient showed up in a doctor's office, the software product would go out, find that data that was out there in the central location, and bring in the data that that doctor needed. And again, we don't bring in all of the data because a cardiologist is looking for certain pieces of data, orthopedic looking for certain pieces of data. Primary care may want to look at all of the data, but basically was designed to bring the data in, pushing the data back to the doctor's office. So as soon as that patient checked in to the doctor's office, we were updating that clinical record with everything that occurred since the last visit. So every doctor had the right information at the right time on the right device, which was their device, that was always updated about what's going on with that patient. That created the value. So we were sharing information between the providers, but we also had a centralized database for doing analytical work, population health work, risk stratification, looking for those patients that had the biggest issues. And we had one personal health record. No matter where that patient went in the community, the patient had one place to log into to find what was going on with all of their care. If they forgot what medications they're on, everything was there for them. A great way of connecting everybody together. And most communities have no connecting of the providers within their community. That's what we need to move towards.
Well, that has already generated some questions from our audience and questions in my head too. But before we get to those, let's look at a summary and what people need to do in terms of practical terms to get this done, to get ready.
I think the whole thing is it's coming. So, you got to start preparing for it. You may say, no, it's only 2% of my reimbursement today. We know Medicare is moving to 50% of all the reimbursements moving to this by 2018, which is really October of 2017 is when the Medicare fiscal year starts. So it's really starting October of 2017. You can't wait. You can't go out and buy technology in 2017 or 18 to start doing this. You need the technology in there today. You need to be analyzing your population today. You need to be figuring out what your cost is. If your cost to take care of a diabetic patient is $15,000 per year and they're only going to offer you $10,000, you may or may not want to take on that contract. How good are you at monitoring those patient stuff? So you got to start looking at all this. Start building it today. Start looking at that next generation enterprise-wide technology that's built for the clinicians, not a financial system. You still have to have that for the fee-for-service patients, but you've got to create that next generation system that's really driving clinical care, clinical protocols, and clinical alerts at the point of care so that the care coordinator can look at this and the physicians can now monitor patients that are not compliant instead of waiting for them to show up in the emergency room. But again, I think this has got to be driven by the physicians. Physicians have to have a leadership authority in this to really create the clinical integration and improve outcomes. Financial people cannot improve outcomes. Yes, I'm an IT guy. Yes, I work in administration. But it's up to the doctors to get them involved because they have to have the incentives to improve the overall health of the population. And financially, they got to be incentivized around that, but we got to provide them the right tools for this. Because again, in 2018, either we move towards a technology-enabled, value-based reimbursement system, or physicians just need to join a large IDN, but then they lose their independence. Doctors want to stay independent. They want that. They want to control their own destiny. Working for a large IDN could be okay for younger doctors, but I think most doctors that have been out in the field for 10 or 15 years, they like that control. They want to control their own destiny. They don't necessarily want to work for a large hospital system. So start looking today is what we're saying.
Well, I'm glad that we have plenty of time for questions. We have questions from our audience. I have to say that I thought that was a great presentation, Mark, because it really helped me understand what the stakes are here. We hear about interoperability a lot, but, you know, good luck trying to connect Epic and Quest and all those different technologies on your own without any kind of integrating software that can help organize that in the way that you described. So that was really interesting. Thank you so much for that.
Well, I got some questions, I understand.
Yeah, let's get to those questions. I'm just reading them over here. Now, one person, this is more a comment than a question, but I think it goes to what you were talking about, your incredibly high deductible that gave me heartburn. It's not even mine. This statement is, the higher the deductibles become, the less likely patients are to seek care until they are very, very sick. So there's kind of a perverse effect of high deductibles. Would you care to comment on that?
Yes, that is a major problem today, because if all of a sudden I know I've got a $3,000, $5,000, $7,000 deductible, I'm not going to come and get care because I can't afford it. I can't afford to pay that kind of money. So I'm going to push off the care till later. That's going to hurt. So we got to find ways, and there's some new programs out there that are looking at new financial, really new financial systems for that patient. All of a sudden, you come in and all of a sudden you have a kidney stone, and you go to the emergency room, all of a sudden you get a $15,000 bill. What do? We got to be able to set them up on a payment system right off the bat. Or if I'm going to have some kind of procedure done, it's going to cost $1,000, my out-of-pocket's $1,000, find a way of spreading that payments over time. Remember, a lot of people have health savings accounts. So by December of the year, they have the money saved up. But in January, February, and March, their health savings account may only have $100 in it. But at the end of the year, they're going to have the whole amount. If I can just spread those payments out, $100 a month, then my health savings account is going to cover all that cost at the end of the time. So we have to find ways of not charging the person $7,500 up front, but finding a way of financing that over a period of time. And the interesting part is the doctors and the hospitals don't want to do the financing, but there's some really nice programs out there now that are finance companies are financing health care over a longer period of time, because most patients are only going to have maybe a program where I'm going to have to pay out, say, a couple $1,000s once every 3 or 4 years. If I can spread those payments out, or if I know that I can spread these out, then maybe I will get more tests done, get more preventive care done. The interesting part is going to be is, if I'm a chronic disease patient, how much of that deductible I have to pay. And that's one of probably the biggest questions going to be. For patients who have chronic disease that are part of these plans, there is no billing system. There is no reimbursement system for it. The hospital's getting a lump sum. What's the patient have to pay? And that's not been clarified yet. But for people that are generally healthy under the fee-for-service system, we have to have a new way of allowing them to pay over time. And again, there's some really good new financial systems out there that the hospitals and the doctors are signing up for that provide financing of those healthcare procedures.
That's really interesting. I have not heard that before. So here's another question. The question is, are ACOs another layer? I'm not completely sure what they mean by that, but they also ask, who accredits ACOs?
Well, right now it's Medicare, because an ACO is a Medicare designation. What we're going to have in the future, though, is you're going to have to be called credentialed. So your organization, a health system, which you can call like an ACO, will be accredited by Medicare. That'll get your ACO designation. But then Aetna, Cigna, United, and the Blues are also going to have to credential all those. And what's going to end up happening is, I am Aetna, and I have 4,000 diabetic patients in the geographic area. And I'm going to say which hospital system wants to bid on it. As long as you meet our quality indicators, your doctors are credentialed, and everything else, then we'll give you that contract. But hospitals will be competing for the same contracts, the same healthcare plan. So it's all going to be credentialed. Will there be a certification program? I think there will be too. But we start with credentialing, the facility, and the hospitals. And most, Aetna already has their credentialed hospitals. But certified will be not only my credential, but I can exchange data electronically with the healthcare plan. I can provide daily, weekly, monthly monitoring of those patients that are assigned to me based on the quality indicators of that healthcare plan, and I'll be sending that to them electronically. No more of this reporting once a year or 3 months after the fact. It's going to be real-time reporting of that population, risk stratifying it, and telling that healthcare plan, here's what our plan is for these 10 patients that are not in compliance. It's proactive healthcare, which is what we have not had in the past.
Well, this is a related question, and this is something that I know a lot of providers have anxiety about, because I hear this a lot, and I'm sure you do too. So the question is, what happens to the non-compliant patient? No provider is going to want to take care of them, so they may get sicker and sicker. But I think the concern on a lot of providers is, what if they really try to get their patients to comply, and the patients just won't?
So that was one of the big things we looked at when we set up our ACO up in the New York area. Again, this was run by the physicians, so the hospitals were just an entity that the doctors would go to. So this was a physician-run organization. And that was one of our questions is, if we have non-compliant patients, what do we do? Part of that is the credentialing and contracting with the healthcare plans. And you may come back and say, look, based on our review of the population, that's why you have to have the risk stratification, that we found out that 8% or 10% of the patients are never compliant. You got to build those into the contracts so that their goal is, of the 90% of the patients that are normally compliant, how you're monitoring those, and you have a buffer for those non-compliant patients. You got to build that in, but you got to know up front which patients are going to be not compliant. That's why you got to have this technology in there today to be analyzing all of your patients, which ones are compliant, which ones are not compliant, starting today, so that in 2018, you know what percentage of your patients are not compliant. You may be running 20% are not compliant. You need to know that before you sign contracts. That's why you need the technology today. Yeah.
That is a great point. In fact, we're almost out of time, so if you wouldn't mind, you've provided us with so much great information. Could you tell us a little bit about what Care 360 does? How they can help people with these problems?
Yeah, is anybody else online? I'd like to turn that over to the IT specialists that talk about that product. Is the Care 360 person also online right now?
He is. He's muted, but I think he'll unmute here in a moment if he's able. I hope I didn't mute him. Let me see if I can.
Yeah, hopefully he'll be able to talk about what Care 360 and Quest Diagnostics is doing.
Well, in any case, it looks like he may not be able to unmute. I'm not sure. But so the point here is that Care 360 is able to implement some of these technologies. Is that right?
Yeah, if you think about the Care 360 side, I've worked with them. A lot of my clients actually are using the product. It's really designed, again, it started out really designed for the smaller physician groups so they can connect in with this enterprise-wide system, because what you don't want to have happen if you're a 2 or 3 or 5 or 10 doctor physician practice is that all the business goes to the hospital and they just use their employed physicians. You want to be connected. And the most important thing is I am on a software product that I can connect to the Epics, the Cerners, the Allscripts, the Meditech products. I need the flexibility. I need to have a product that meets my requirements, but I can also connect in. And how simple is it for me to integrate in with that larger system so I can share all that information? Many of the vendors out there today basically are silos of information. I have that one vendor's product in my one practice. Get rid of the silos and open it all up. And that's what Care 360 does, is it really opens it all up so I can see all the medications, all the lab results, bringing everything together in a simple model where I can provide the best care I can. But that data is also shared within the enterprise so somebody can be doing that risk stratification and telling me which patients I need to see, and having that data, that care plan, that clinical alerts show up on my desktop within my Care 360 EHR product. I don't want to use 3 different products. I want to be in my Care 360 and be able to see those alerts.
Well, I think you actually did a fine job of describing it, but Colby, would you like to add to that?
There we go.
Actually, I was going to say Mark did an excellent job of advocating.
He really did.
Yeah. Really just wanted to do just the quickest of overviews here to respect everyone's time at the end of the webinar. But Care 360 does offer a complete suite of solutions, and of course we're back 3,000 physicians in over 125,000 locations. Our network is extremely broad and quite strong, and really helps you from the moment the patient walks in right down to billing and collections, as well as some of the points that Mark spoke to earlier in the webinar about having a great patient portal, something that you can really work to communicate with those patients on, and really to be able to focus on your patients more and not so much on all of that back end. To have it be such a one-stop shop is something that we take a lot of pride in, is putting together a product suite that works really seamlessly together from beginning to end.
Yes, and that is quite rare out there in the healthcare universe, I have to say, because it's certainly the kind of coordination that's required for ACOs, you can see that it's clearly not there for most of them, as Mark's presentation made clear. So I just want to remind our audience as we wrap up that you're going to receive the slides in an email. You're going to receive a video recording of this. I'm glad we got over our brief sound problem that we had. That was great. And I want to thank Mark for joining us today. If you want to learn more about Care 360, you can see their URL on your screen. You'll also get that follow-up email. We are happy to present these learning lunches at Format Approved. And so if you want to sign up for the next one, you can go to our homepage and register there. Mark, before we close out, if you have any final words, I'd just like to thank you again for joining us today.
I think the final word is, we're there now. Yes, a lot of this reimbursement won't change until 2018, but as I said, you need to get the technology in there now, so start analyzing these patients, find out what your costs are, find out what percentage of the patients are not, that are not compliant or at risk stratification. But you can't wait. If you wait till late 17, 18 to start working on this, you will wait way behind. You won't be able to compete effectively for these contracts. And again, all this is based on real data that we did by looking at the 223 ACOs out there. The ones that had the data available to them in a usable format were the ones that saved money and were successful. The ones that did not have the technology were the ones losing money. And in this thing, you're moving all the risk to the provider. You don't want that provider losing more money, because then they're going to get out of the program, and we're not going to improve the overall health of that population.
Well, that's a great summary, and thank you again for joining us, everyone. We look forward to you joining us for the next Learning Lunch, and look for that follow-up email from us. Everyone have a great day. Remember that the time is now to get ready for ACOs and pay for performance. Thank you so much, everyone. Goodbye.